In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the third edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the retina world community.
Hello, everyone, all retina specialists from the world. Today is December 15, 2019. Today is going to be the last event from our. Today we have a great team from European Vitreoretina Society. Then we're going to talk about a special topic, insight into tractional maculopathy. And today we have my co-moderator, Kishi Singh. That's a former president of RWC, and he's going to introduce my special friends. Hi, Hishi.
Hi, George. Thank you. Thank you for leading this webinar today, and thank you for all of you watching at home. This is the culmination of many years of work and effort to unite the retina societies from across the world. And we're privileged today to have one of our 44 participating societies join us in the webinar today. This is the European Vitreoretinal Society board members. We have Dr. Gianpaolo Gini, who is joining us from London. We have Ivan Fischer joining us from the Czech Republic. We have Dr. Senegal Ozek joining us from Turkey. And we have Dr. Barbara Parolini joining us from Italy as well. So thank you and welcome to the webinar today. We're going to be talking about myopic macular schisis and how many ways we can address it. But before I turn it over to my co-moderator, George Roca, I wanted to remind you that our meeting is on February 18th to the 21st, 2021. And the early registration will actually open in January. So for those who are interested, we'll have open registration starting in January. And I hope you can all join us. It'll be in Fort Lauderdale, Florida, at the Marriott Harbor Beach, the hotel that has been famous from past ARVO meetings. And we hope you can join us at this exciting meeting in February 18th of 2021. George?
Hi, everyone. Today it's good. And the RWC main purpose is connecting people. Here we are doing that. We are connecting people from different countries and on live. And this is very important for us. And we encourage everyone that is attending now to address some questions. And we are open, everyone from the 44 society that's partnered, to join us and help to build this connection. The world of retina now is transformed, but the good thing is transformed for friendship, for connection people. This is the idea. Now we're gonna have Barbara, that's from Italy, and she has a great topic that's gonna share with us, great insight about myopic maculopathy. Hi, Barbara, good to see you.
Hello. It's a great pleasure to be here with you. Yes, as you mentioned, my topic will be myopic traction maculopathy. So I will start sharing my slides with you. For sake of time, I will go straight to the topic. All right. I hope you can see them. So I will start. Perfect. So I entitled the topic, The Nasty Smile of Myopic Traction Maculopathy, and most of all, how to get rid of it. The topic is pathologic myopia, which is myopia in eyes higher than 26 millimeter of axial length or myopia above 6 diopters. The prevalence of high myopia in the world is 2% of the population, although it is more concentrated in the Mediterranean area and in Asia because genetics is very significant in the pathogenesis of high myopia. And among the myopic population, 30% are affected by a sort of myopic traction maculopathy, which will shorten in MTM. You can see in the picture an MRI of a typical eye with high myopia, which is elongated and very different from the usual shape of the eyes. And you can see an OCT overlapping the posterior pole of this specific eye with myopic traction maculopathy. So we ran a study in 2018 on MTM with the following aims: to study and clarify all the types of MTM, to study the natural history, the pathogenesis, and most of all, to propose the best management, but customized per each type. Why? Because MTM is not just one disease, it is a whole spectrum of clinical pictures. There is no comprehensive classification at the moment, and there is no consensus on management. If you look at this picture, they remind me a smile, a gentle smile. These are a nasty smile, and these are unbearable smile because they are laughing at us because we don't know what to do and how to deal with that. So in the first phase of the study, I have reviewed 281 eyes with MTM that I have operated since 2016. And I classify the MTM subtypes only based on the preoperative OCT appearance. I have identified 4 types of patterns into the retina and 3 types of patterns into the fovea. We will look at them one by one. So type 1 is schisis in the inner layers or inner outer layers. You can see the mean age of the patient is fairly young and the visual acuity is good, 0.5 decimal. In fact, the photoreceptors are attached, so this patient can see very well. In type 2, the schisis is predominantly into the outer layers. The age is older, which is significant, and the visual acuity is still good. Type 3 is the combination of schisis and detachment. And in fact, since the photoreceptors are detached, the visual acuity drops dramatically. In type 4, finally, the retina is completely detached and no schisis is visible. And the visual acuity is obviously low and the age is older. Per each type of pattern into the retina, The fovea can be normal or, let's say, intact in type A. In type B, we have a lamellar macular hole, and in type C, we have a full thickness macular hole. Associated findings might be any sort of epiretinal abnormalities, which can be identified with the plus sign in the classification, or an outer lamellar macular hole, which is a splitting into the photoreceptors layer, so in the outer retina, which will be identified with the capital O. Remember that there is a significant correlation between types and age, being type 1 and type 2 in younger patients and type 3 and type 4 in older patients, and the difference is statistically significant. So then I focus on the natural history of these eyes with MTM, studying a great number of eyes that could provide me at least 3 OCT taken at different timings with an interval between one OCT and the others of at least 1 year. These eyes obviously were not operated, and I could collect a very long evolution up to 10 years. You can see an example. This patient of a male is a male of 49 years of age. In 2008, he has a barely visible schisis. The vision is very good. And as you go down the ears, you can see the schisis is deepening into the outer layers. And in the bottom right slide, you can see evolving into retinal detachment with a drop in vision. But these eyes can also enlarge, not just elongate. This patient from a lamellar macular hole, he develops a full thickness macular hole associated with the schisis. So, considering two things. One, that there is a correlation between type and age. And two, that there is an evolution in the same eye. We concluded that MTM should not be divided in types, but in stages. It is a staging, evolving system. So we proposed to validate what we called MTM Italian staging system, shortening MIS, because we were looking for an easy name to remember. I hope it will be validated and Italian can become international. So you can finally see this single table that summarizes all the concepts that came out in the study. You can see the perpendicular evolution, perpendicular meaning perpendicular to the foveal plane, from schisis to detachment. And from left to right, you can see the tangential evolution in the fovea, from normal to lamellar hole to full thickness macular hole. Per each type, we have added the average vision and also how long is the time taken to switch from one stage to the next, so you can talk with your patient about prognosis. We can see some example. Here there is a schisis in the inner layers. The fovea is intact. There is some epiretinal abnormality. There is no lamellar hole in the outer layer, so it will be stage MIS 1A+. In this case, the schisis in the outer layer. The fovea is still intact, no epiretinal abnormalities. There is an outer lamellar hole, so it will be stage MIS 2AO. And the implication of treatment are significant. Those are the main points. I have studied 157 eyes with MTM that I could follow for at least 2 years. This group of eyes was operated either with bacular buckle or vitrectomy or a combined procedure. The aim was to study the anatomical and functional response to the treatment per each stage of MTM. And the conclusions were that the retinal pattern from schisis to detachment should be solved by the macular buckle because the forces which are perpendicularly evolving in the retina should be pushed. And the foveal pattern, the tangential forces, should be peeled. The holes should be peeled. let me show you what I call the game of traction on the fovea. I will move forward to show you this picture. So if the main force that is causing the problem is tangential to the foveal plane, causing a splitting in the fovea, we should apply a parallel force, but in the opposite direction. So still tangential to the fovea, like with what we can do with vitrectomy and ILM peeling and close the hole. But if the main force causing the problem is perpendicular to the retina, like in this picture where the sclera is detaching from the retina, we should push from behind with the macular buckle only to treat the problem. And if the forces are combined, like here, tangential splitting the fovea and perpendicular detaching the retina from the sclera, we should combine the treatment with vitrectomy and buckle. So the same table can be now completed with guidelines to management, which are different and customized per each type. You can see type 1A, type 2A. My advice is observation, because vision is very good, and the time taken to evolve to more severe stages is very low. But if you go to type 3, or better, stage 3A or 4A, we should treat immediately, because the natural history is very bad and these eye will lose vision if we don't treat them, and the base treatment is macular buckle. But if we move on the right with lamellar hole and full thickness macular hole, if there is no schisis, we should apply only vitrectomy and maneuvers on the ILM, like ILM flap. If we have holes and schisis or detachment, then we can combine the procedures. So this is the main point of my talk. I really hope that a wide group of colleagues will try to validate this classification and this type of management suggestions. I could stop here, George, if you want. We can discuss about the classification, or if you want, I have a few slides on the macular buckle based on how much time we have. I can do it later if you want. I cannot hear you, George.
Sorry.
Yeah.
Here, I think you should go on and finish.
Okay. I hope you can hear me. I cannot hear you.
Can you hear me?
Yes. Yes.
I think you should go on and finish the buckle and vitrectomy. We have time.
I will show a few videos then, just to see what a macular buckle is. I will move to the slides with the macular buckle. Okay. So this is the model of macular buckle that I'm using. You can see in the figure with the B, it's a sponge, silicone sponge with a titanium stent inside. I will show you how I make macular buckle at the moment. I use a titanium stent that I insert into a sponge. It's the 507 model sponge. And then I can bend the titanium stent as an L and cover the lateral arm of the titanium stent with a silicone sleeve. And this is how we can insert a buckle even without vitrectomy. You isolate the temporal and superior rectus muscle, make a paracentesis, and you can insert the buckle in the superotemporal quadrant. I use a fiber optic into the buckle to use the transillumination to locate the buckle. Then through the microscope and the panoramic viewing system, you can see and really check with precision where the buckle is and how to indent. So now we have the help of intraoperative OCT, and even under ERA, we can see exactly the indentation and the location of the buckle to be more precise. After locating the buccal, we can mark the position of the sutures, which are very close to the insertion of the muscles. And then we can pass one or better two sutures anteriorly in a very well exposed area to fix the macular buccal. You will see even better in the next video how to fix the buccals. So here was a surgery of a combined surgery, vitrectomy and macular buccal, again inserted in the supratemporal quadrant. You can see underneath the transillumination to check the position and the intraoperative OCT. And again, how to suture a buccal anteriorly, very anteriorly in a very well exposed area. This is an example of evolution from pre-op. You can see a detachment and schisis, so it's type 3A. And after the macular buccal, you can see a progressive resolution of the detachment with improvement in the microperimetry, as you can see on your left, and in visual acuity. Again, another evolution from pre-op to 9 months post-op, a great improvement in vision and microperimetry just with the buccal. And this is another example. That this is the patient that I have operated at Floretina. It was a detachment with the macular hole. You can see from pre-op, look at the scotoma on the slide top left, that completely disappeared in a few months after a combined surgery, buccal and vitrectomy, with great improvement in vision. So I think these guidelines could be very helpful to help and let us know what to do with these very difficult patients. I can stop here. Thank you.
Very good, very good. I think we should move for the next talk with Segu, and after finish all the talk, we can stop and discuss the topic. What do you think? We should go there. Please,
Okay.
Dr. from Turkey, we are very anxious to see your talk. Open the phone.
Okay. Can you open my voice, please?
Yeah, everybody's hearing you
Okay.
very well.
So I'm sharing my presentation. Can you see it right now?
Yes, beautiful. Perfect.
Thank you. First of all, good morning, good evening, have a good day, because time is different everywhere. Now it's almost evening in Turkey. I would like to share with you my experience on pneumatic vitreolysis for vitreomacular traction syndrome. You know that posterior vitreous detachment starts from perifoveal area and continues with the fovea and around peripapillary area, and the last one is the optic nerve head, and it's complete PVD. And when there is an anomalous PVD, the peripheral separation often causing vitreomacular traction or vitreopapillary traction. Is predominant in females, and it usually occurs at 6th or 7th decade. And it may be asymptomatic, or it may cause visual acuity decrease, metamorphopsia, and central scotoma. First of all, foveal contour starts to deteriorate, and macular cyst formation comes after that, and foveal detachment may follow it. And later, it can detach spontaneously or may cause epiretinal membrane formation or macular hole formation. This may also provoke diabetic macular edema and neovascular AMD. And if it fails to detach from the optic nerve head, it may cause vitreopapillary traction also. This may lead to optic disc swelling, and it may be misdiagnosed as non-arteritic anterior ischemic optic neuropathy. And this is such a case. I just want to share it with you. As you see here, there's optic nerve head edema. Since there's some cataract, it's not so clear, but we can see it in the OCT very well. And it was referred to us with the diagnosis of anterior ischemic optic neuropathy, and there was also subfoveal fluid. And we discovered that it's because of the vitreopapillary traction, and we just let it go for some time, and we followed it for 2 months. And then, as you see here, the optic nerve head has totally gone, and there was no traction because vitreopapillary traction has resolved spontaneously, and also the subfoveal detachment resolves spontaneously. So we should think about this also in the optic nerve head area. As you see here, optic nerve head is totally almost normal with the separation of the traction. And coming back to the vitreomacular traction, we can have again spontaneous posterior vitreous detachment, and it has been reported in the literature up to 47% of the cases. But PVD does not always end up with anatomical healing. We can also use ocriplasmin, which is enzymatic vitreolysis, or pneumatic vitreolysis, or vitrectomy in selected cases. When we look at the natural course studies, in one of them by Odrobina and his colleagues, there was 47% vitreomacular traction release within 8 months, with a mean follow-up of 8 months follow-up, and 67% of those with PVD became normalized with this spontaneous release. And in those with total normalization, vitreoretinal adhesion was much less, and there was no epiretinal membrane. And in those who did not detach, there was broad-based vitreoretinal adhesion with epiretinal membrane, and they ended up with either lamellar hole or full-thickness macular hole, progressive decrease in vision, and they needed surgery. In another one, in another study, vitreomacular traction release was 44% within almost a 2 years follow-up time. In a study by American Collaborative Retinal Group, VMT release was 21%, so much less than the previous ones, but unfavorable anatomical outcome occurred only in 7.7% within a year follow-up time. So follow-up without doing anything is another choice. As you see here, spontaneous release may be seen in these cases, especially if they are not symptomatic. Ocriplasmin is another choice, and it has been reported in MIVIS studies that 40% has been released with the ocriplasmin injection, but they are in selected cases. There shouldn't be an epiretinal membrane, for example. And there are some disadvantages with this ocriplasmin. We know that it has a cost, it's an expensive treatment, and it has some adverse events like transient visual loss, ERG changes, lens subluxation, retinal breaks, etc. And vitrectomy may be an option, especially in broad-based vitreomacular traction cases, and so especially if they are associated with epiretinal membrane. But we know that there are some concerns about it, like cataract formation, retinal tears, retinal detachment, and endophthalmitis. So this is one of our previous cases, maybe 10 years before, with a visual decrease in one eye with vitreomacular traction, treated with vitrectomy. She had cataract and had cataract surgery afterwards. And there's a meta-analysis in the published in Retina in 2015, looking for different treatment options for vitreomacular traction. When we look at those results, they have shown that pneumatic vitreolysis has the highest rate of vitreomacular traction release as compared to ocriplasmin and the control group, and also has the least complication rate as compared to ocriplasmin and vitrectomy. So these were really attracting for me. And firstly, actually, pneumatic vitriolysis was suggested by Chen et al. In 1995. They have used C3F8 gas and face down positioning, and they have reported PVD induction in 18 of 19 cases and macular hole closure in 3 of 6 cases. But later, Steinel and friends has to this maneuver with drinking bird maneuver. And it was repopularized, especially for me, I should say. And we have started our cases then. We have done pneumatic vitriolysis in 13 eyes, and 11 eyes were vitreomacular traction. We have used SF6 gas for these eyes, and we have done pneumatic vitriolysis in 2 macular hole cases, with small macular hole cases with vitreomacular traction. We have used C3F8 gas for this. And we have followed them with OCT in first, third, 7th days, and then weekly afterwards. It was, this is my technique. It's an office-based procedure. I use just topical anesthetic and do limbal paracentesis first to soften the eye, and gives gas injection and bird feeding head movements. It is like every hour or half an hour, 10 to 15 times like this in this picture. And we check the vitreomacular traction with OCT, and if it is detached, we stop head movements. If still there, we continue till 2 weeks, then stop it. And we check for the retinal breaks, of course, during the follow-ups. And this was, I just want to give some examples to you. This was one of the cases. I have started to follow the case starting from 2012. My vision was 0.6, and it was like that. An epiretinal membrane was becoming more apparent within follow-up time. In 2014, it was 0.5, a little bit decrease in vision with some epiretinal membrane. But when I see this bird feeding maneuver, then I wanted to try it. And in 2016, I tried this technique, I mean, in the pneumatic vitriolysis, and you see it's just 8 days afterwards, it was totally separated. And vision became 0.7, although the cysts are still there because there's some epiretinal membrane there, but there's no progression, and vision was better. Another case, as you see here, the right eye had a little bit of vitreomacular traction, but it was kind of asymptomatic and no metamorphopsia. But the left eye, as you see here, there was a very broad-based vitreomacular traction causing foveal detachment. It was a very severe one. So I did vitrectomy to the left eye, as you see here. After vitrectomy, ILM peeling, vision started to improve. It was a long-lasting vitreomacular traction, actually, and become better. During this time, the right eye become deteriorated. As you see here, vision dropped more, and then I decided to do pneumatic vitriolysis for this case. And just one day, as you look at the dates here, just the next day, the vitreomacular traction was released, and as you see here, the fovea was totally normal after pneumatic vitriolysis. This is the right eye, and this is the left eye. Another case, almost causing a full-thickness macular hole, and we did pneumatic vitriolysis. Just 2 days afterwards, it released, and this is 7 months afterwards, and the foveal contour is quite nice. Another case, you see vitreomacular traction there. It's not a broad base, but a very narrow base traction. And we did again just the next day release, and you can see 2.5 years after, vision is quite well without any epiretinal membrane formation. Another case, as you see here, 2 days afterwards, and with follow-up 6 months, vision is 0.9. So this is another a little bit broader vitreomacular traction with dry AMD, associated with dry AMD. 9 days afterwards, it was released, and you see vision improved a lot. This was an interesting one because she had bilateral vitreomacular traction, and she was referred to me for vitrectomy actually. And I did pneumatic vitreolysis to both of the eyes, 1 week apart, and one in the second, the other one in the third day. The traction was released, and as you see here, foveal contour was quite nice with 0.9 vision. However, in macular hole cases, it was not so good. I mean, the results, although we had some release, we couldn't have closure in both of the eyes. As you see here, just the next day, pneumatic vitreolysis in the 4th day, PVD occurred, and we have used C3F8 gaze in macular hole cases and continued with the face down positioning afterwards for a week, but still did not close, and I had to do vitrectomy afterwards for this case, and it's now closed. So when we look at our results, the mean age was 67 years, and our release rate was 100% in all of the eyes. The hole closure was 0%, just in 2 cases we tried, and mean time for vitreomacular traction was 5 days. And when you look at the results, the horizontal vitreomacular adhesion was not too high. The maximum was 630 microns. They were usually narrow-based vitreomacular tractions. And when we look at the complications, we have just one retinal break in a myopic, and he said that I shake my head a lot, probably because of that. And we lasered it successfully. There was no problem afterwards. And in the literature, the vitreomacular traction release was not that bad, as you see here, around 80 to 70%. And everybody advised that horizontal vitreomacular adhesion should not be too wide. Vitrectomy is a good option if it is a wide-based vitreomacular adhesion and if there is an epiretinal membrane. To conclude, if you have a vitreomacular traction, if the visual acuity is good, there is no metamorphopsia we can observe. If there is a wide-based vitreomacular traction with epiretinal membrane, we can do vitrectomy. And if the patient is a young patient and the cost is not an issue, and if there is no epiretinal membrane, ochriplasmin may be tried, but pneumatic vitreolysis seems to be an effective, minimal invasive, quick, and low cost and safe method for these eyes. I just want to invite everybody listening us to the EVRS meeting next year in Verona. Thank you for listening to me.
Thank you very much, Segu. Very good talk. Very good talk. Unbelievable. And I think you should go on because we have time now. And Ivan from Czech Republic, you can go for the case. And after that, we stop for some discussion. Ivan, please. You need to turn on your phone. We can't hear you, Ivan. You have to turn on the microphone. Yes, good, very good.
Can you hear me now?
Yeah, perfectly.
It's fine. But we have to go back. Okay. So, dear friends, I am very glad to participate in this interesting meeting, which is my first experience with a web meeting like this. And I have to thank Barbara for telling everything about the perpendicular and horizontal tangential tractions. So I can skip over this and go directly to the case report of a 35-year-old male who presented with degenerative myopia. He was after refractive procedure for 12 diopters and later regressed to 6 diopters. How can I get rid of these photos like that? The left eye was perhaps amblyopic, and he presented with right eye visual acuity 0.8 and left eye visual acuity 0.25. He suffered from central scotoma in his left eye and from bilateral metamorphopsia. There was a pronounced staphyloma and hypopigmentation of the whole fundus. And after 2 months, he felt some improvement of the right eye, but still some distorted vision of left eye, even if it improved to 0.5. And there were some petechia in the macula, and we thought that it was a spontaneous release of vitreomacular traction. How can I? All right. This is not correct. This is right. But there was no PVD, as you can see. There was vitreomacular traction, and there was a lot. After 11 months, it means after 2 more months, there was still distortion of his left eye vision, and he felt a scotoma, and he wanted a surgery. Unfortunately, in the documents, it was written that the left eye visual acuity was 0.6, which was a nonsense. He referred that he could see nothing, and he had a myopic foveoschisis, inner and outer, and there was a small foveolar detachment. It was 10 years ago, and we did not hear Barbara's presentation, so we proceeded with the surgery, and we performed a difficult PVD and ILM peeling. Finding pronounced pigment and neuroretinal atrophy, we could not exclude a small macular hole, so we applied SF6 gas. After the surgery, the patient improved subjectively. The scotoma was only gray, and the vision stabilized on 0.1. And he was very happy. He said, before the surgery, I could not see anything. And we could see a light spot in the center of the macula. Now I am going to show you, this was 20 gauge surgery. So this is how we performed the posterior vitreous detachment. You can see the atrophy of the posterior pole, staining with trypan blue, trying to detach the posterior hyaloid, which was not easy. Now vacuum peeling the posterior hyaloid from the macula. And very carefully peeling the ILM. You can see some hemorrhages from difficult posterior hyaloid detachment. Now dissecting the posterior vitreous face and applying gas SF6. So after the surgery, there was some pigment atrophy. We could not exclude the macular hole in the left eye, but the patient came with petechia in his right eye, and we could see vitreomacular traction in the right eye. Now look what happened in the left eye. This was a very unfavorable outcome, and the patient had a large, flat open macular hole. But he was not unhappy, surprisingly. He had very similar symptoms in his right eye. You can see adhesion of the vitreoschisis to the temporal edge of the fovea and beginning lamella defect and some petechia here in the macula. Then he felt a yellow spot in his vision of his right eye, and we found some subretinal hemorrhage which looked as really subretinal, so we used fluorescein angiography to exclude the CNV successfully. Then he felt further worsening. He was losing letters when he was reading, and he had distortion of the Amsler grid, but still his vision was 0.8. And you can imagine why we postponed the surgery of the right eye due to the course of the left eye. But in the right eye, there was further worsening. You can see inner and outer foveal schisis. And in black and white, you can see that there was beginning a pseudo hole or lamella hole. And later, yes, and the left eye looked like that. So we really did not want to operate the right eye. But he felt more distortion. His vision dropped to 0.5. There were new petechia, and a small outer lamellar hole or foveolar detachment appeared. You can see the large staphyloma over the whole posterior pole. Then another drop of vision to 0.4, but he still could read Jaeger 3, which we could hardly improve using any kind of surgery. Later, a macular detachment, Barbara watched it, how it was unfavorable, appeared, and even an outer lamellar macular hole. And he had a black scotoma because of the detachment. Then he was losing letters when reading, but he was resigned. He did not want the surgery at that moment. But later, you can see that the outer lamellar defect, macular defect, enlarged, and his vision worsened to 0.2, and he could hardly read Jaeger 8. And moreover, he saw flashes of light, and the traction got worse. So now we have a patient with vision drop to 0.3, positive absolute scotoma, metamorphopsia was worsening, and the traction was worsening. Should Barbara perhaps would advise macular buckle? Another option is watch and wait, or what should we do? Not knowing how to perform the macular buckle, we performed another vitrectomy in the right eye and peeled the ILM with maximum delicacy. This time it was done in the 25 gauge manner. And you can see that the right eye was no better than the left eye. And we peeled the ILM very, very gently. I know that the option is to leave the central portion of the ILM. In this case, in the hypopigmented macula, this was not technically possible in my hands. But what I could do was to peel the ILM as gently as I could. Then we found a peripheral tear, treated it with laser, and applied air tamponade only. After the surgery, the finding got nicely stabilized. 5 weeks after the surgery, the OCT looked like this, but 8 months after the surgery, the fovea healed relatively favorably, and the patient was happy with vision 0.4. Surprisingly, he did not feel any improvement. 1 year after the surgery, the vision dropped to 0.2 due to cataract, but he was afraid of cataract surgery. Only later we performed the cataract surgery, and the vision stabilized on 0.2 due to progressive atrophy of the fovea. During the last checkup, it was 2 months ago, he was satisfied. The vision is 0.2. We can see that the architectonics of the macula are relatively preserved, and in the left eye there is a large atrophic macular hole. So the right eye healed after vitrectomy, and the left eye very unfavorable outcome after the same procedure. So the message is that it's always necessary to inform the patient about the risks of myopic traction maculopathy surgery, because the macular hole as a secondary complication after vitrectomy can happen in 19 to 27% of operated eyes, and the chance for reoperation success is minimal. Thank you very much for watching.
Very good. Now I think he's gonna moderate some questions. I have some questions from the audience too. Some people around the world is asking questions. Please.
Yeah, very nice presentation, Ivan. I had a question for you. You showed how the vision subjectively in the patient changed a lot versus the objective number. The number did not change necessarily. And you were trying to make a decision about surgery. Do you or anyone else in the panel have a good way of assessing patients with myopic macular schisis or myopic macular changes? Maybe it's reading speed or otherwise. Do you have anything else to offer us from a vision standpoint? I'll start with Ivan, then I'll go to Barbara. I see also everyone else has answers too. So let's start with you.
Me.
Yes.
Okay. So the scotoma and the loss of vision is mostly due to the detachment of the macula. This is my feeling.
Right.
So I think that Barbara will explain the rest.
Right, Barbara.
Yes. Can I go back to one slide that will explain everything? I would like to share my talk. I don't see the arrow to share. Can you share mine?
Tiago is trying.
Well, if you want to have Sengo, we can hear from you first, and then we'll go back to Barbara while she gets her slide ready. How about that? Sengo, you're on mute right now.
Okay. So, okay. In all the macular problems, objective and subjective vision are usually different because the central macula is already affected. So when you just do the ETDRS or just the Snellen visual acuity may not change, or it may not reflect the real total vision because, the contrast sensitivity, visual field, color vision, everything is there, but you measure just the central macular visual acuity. So especially in AMD cases, similar to myopic cases, the patient feels you measure the same vision, but patient says that I'm much better after the treatment.
Right.
So I can do now these things that I cannot do before. So it's something like that in myopic maculopathy also. What we can do is, the simplest thing is to ask the patient, how do you feel yourself before and afterwards? I always ask this. All the macular problems, I always ask this, if they feel better or not, or worse. Sometimes it's the same, but they can say that it's worse than before. So I ask the patients first. And secondly, if you have a microperimetry, it helps a lot. I think that's all.
Yeah.
Great. Okay, Barbara?
Yes, I'm okay. In fact, starting from where Sengul stopped, I can say that microperimetry helped me a lot understanding this patient. They can develop extrafoveal fixation. And with microperimetry, you can really follow the improvement. I would like to thank Ivan because everything he said is just validating what I presented in my talk. First of all, he said that the chance of ending up with a full thickness macular hole by just doing vitrectomy and ILN peeling is very high. I can confirm that. And in the right eye, Ivan, you said that vision did not improve so much, even if fortunately you did not have a iatrogenic hole. But it is because you had an outer lamellar hole, which is a splitting into the photoreceptor. And what happened after surgery is the retina flattened, but the outer macular hole remained. So you have an area with atrophy. And that is the reason why the patient did not recover vision. In those patients, if you could apply a buckle, as you can see in this slide, there is a small outer lamellar hole that completely closes 9 months later. And so you have an improvement from 0.1 to 0.8 vision. And you can see on the left a full restoration of microperimetry. Look in this patient as well, the big scotoma on the left, the black area is a big scotoma that completely disappears after surgery. That is why I am saying that if we have only detachment and no splitting in the fovea like you had in your cases, Ivana. Just schisis or schisis detachment, it is much safer to push. No peel, just push with the buckle, because the case will solve and the vision will improve. Instead, if you have a hole, then you have to make an ILM flap to close it.
Very good, very good. George, you had some questions from the audience as well?
Yes, I have some questions from the audience. Let me read here. Our friend from Buenos Aires, Ezequiel Rosende, he asked Barbara if we have different size of buckles, and if yes, how to measure what's the length of the device to use in different size.
I understand. You know, it is a very good question because the axial length can be so different in these eyes. But what I ended up doing is to use the same length. I always use the same shape of buckle because it is much easier. And what I change is the distance from the limbus. So I insert the buckle, I look through the panoramic viewing system to check the final position, and then I mark the where to suture. So no real need of having different sizes because we can change the position.
And I have another question from Pakistan, Dr. Hannah. She asks that, do you have companies that sell this buckle, or you made in the OR? How you handle that?
So far, there are a few commercially available models, which I don't really like because they might induce atrophy in the macula. So I prefer to use it that pushes the macula, and I am using still an off-label model that I make in DOR. Hopefully, I will have a new model in a few years. It will take a long time, but I am using. I'm making it myself.
Another question for Marcelo Zas from Buenos Aires. He asks you, what's the tips and how you teach us the learn curve to put a buckle? What's the 3 tips for start to put a buckle?
Well, it is easy, but it's not so easy. I think the main thing is to have, this good model with the sponge in the tip, but to use a panoramic viewing system. Don't do it with the indirect ophthalmoscope, because being able to see is being able to do. So you need the panoramic viewing system and the fiber optic into the pars plana. And then you can write me, I will tell you all the tips because, but I think good vision is the main issue.
Anyone have experience with intraoperative OCT and findings they've seen with these surgeries? Is there something you can tell us about the surgeries and intraoperative OCT that has resulted from this surgery?
Yeah. I have shown you the few videos with intraoperative OCT. Of course, intraoperative OCT in this specific surgery is extremely helpful. I can show you the clips because it tells you exactly where the buckle is, and I cannot move it. Yeah, you can do without because you can see the buckle. But as you can see here, the intraoperative OCT tells you not only where it is, but how much to push. So it is obviously very, very helpful, but you can do without.
Great. Anyone else about intraoperative OCT? Yep, Single.
I can say that although I don't have experience like Barbara, in myopic eyes, the retina is very thin and you cannot even recognize the ILM very nicely, even if you try to sometimes give some dyes to see them better, since there is no contrast in the background. If this, the posterior staphyloma is too much, then even the ILM peeling is maybe very difficult, and you may have some extrafoveal holes, and you may not see them because of the posterior staphyloма. I think intraoperative OCT is also helpful to detect those defects and also to see the other layers of membranes, because there may be more than one layer of membrane sometimes in myopic maculopathies. So it may be helpful to detect them also.
Very good. Very good.
I have one last question from Mexico, from Dr. Rosa Eliza. She asks anyone that after put a buckle, anyone having seen macro atrophy, the RPE and the photoreceptor, like a side effect after place a buckle?
Yeah, that is why I'm still using this type of buckle, because I do not see atrophy induced by the buckle, unless there is an outer lamellar hole that I cannot close. But if the case is resolved with complete closure of the outer lamellar hole, the buckle does not increase the atrophy. I think it depends on the shape and the material, because with the smooth shape and the soft material, I have not observed atrophy. That is why I'm not using other models. Because it is described in literature. She's right. It is described in literature. But this is not an issue that I have encountered.
I know. And now I think we should listen to the president of European Vitreoretinal Society, Dr. Giampaolo, that's going to say some words for the next big meeting that's going to happen in Verona. Dr. Giampaolo.
Hello, everybody. It was fascinating to listen to these presentations, although I've seen them before and I know very well the philosophy behind them by these excellent surgeons that we are privileged in having in EVRS with us. Can you hear me well?
Very good.
Good. So let me just introduce myself. I'm a VR surgeon, obviously, and I've been doing VR surgery as long as I can remember, and that is quite a long time. I fell in love with the retina in my early days in medical school, and with VR surgery long before I met my wife. And those were the early days in which VR surgery needed many things to be done. We needed to learn many things. Many new instruments had to be developed. And every case really represented a challenge. So why am I telling you this? I'm telling you this because in those days, 20 years ago, EVRS, the European Vitreoretinal Society, was born, providing a setting where surgeons could meet to share their experiences, share their achievements with no arrogance, but also their failures with no fear. And this was very important at the time because there was no such society. This was a place where knowledge would be shared among peers. And EVRS gave the opportunity to many of us to grow by learning from others, the possibility of sharing ideas, just as Barbara, Shangul, and Ivan have done today. To me, it gave the courage to pursue my beliefs, even when the official wisdom was against me. And this was the case, for example, when I challenged, together with Ferenc Kuhn, the early vitrectomy study for endophthalmitis, when the whole world was saying one thing, and we were saying the opposite, that we should be doing vitrectomy early and completely, and not what the study at the time said. And again, it gave me the courage to face difficult cases, because when I was called to perform live surgery, shoulder to shoulder with the masters of the time, this gave me the enthusiasm and the confidence to face more challenging cases in my own OR. So I believe that this story is common to many of us, and I believe that Şengül and Ivan and Barbara, because I spoke with Barbara many times about this, share this view completely. So I'm telling you this because the spirit of EVRS is alive today. It has not changed. It's a group of friends that meet to share on a common ground, peer-to-peer, not from the top to the bottom, but in an horizontal way. I always say we share knowledge. We tell each other what we like to try and achieve, what our achievements are, what our failures are. And this is very important to grow and to have a platform to which young surgeons can take off and spread their wings. And we have a meeting every year to do this. This is our annual meeting, and this year we'll be having our 20th. It's our 20th anniversary. We will have the meeting in Verona. Can I have, Tiago, the flyer, please? And it will be in Verona from the 4th to the 7th of June 2020. Please pen down this date. And it's going to be a wonderful meeting because in the true spirit of EVRS, we are going to be having excellent speakers. This year we will have people of the charisma of Mark Humayun, who will be delivering a few lectures, and Giovanni Staurenghi for the medical part of the retina. Also, we will have different societies which will carry out their own sessions, and these will be the American Society of Retinal Specialists, the Russian Society, the Indian Society, Turkish, Egyptian, Italian, and others. So it will truly be a world meeting, shall we say, within the European Vitreoretinal Society. We will also have live surgery, which will be organized by Barbara, and there will be the excellent surgeons to perform this. And obviously, we will have all the contributions from our members with many, many papers. We already have more than 200 submissions. So I will finish here because my time is up by inviting you all to come to this meeting. And again, Tiago, can we have the flyer, please? And if not, just look it up on the website. It's evrs.eu. Please come. We'd love to have you. Thank you.
The flyer is already on, just because we can't see it's your side. I can send you the screen that I just took a picture, but it's beautiful.
I can show it if it is possible.
Good. Wonderful. Wonderful.
I can show it if it is possible.
Yeah, please share.
Okay. I will. In a minute.
I have.
Okay. So don't waste any more time. Thank you so much.
That's here.
Well, thank you.
And of course, Verona is the birthplace of Romeo and Juliet. So if you've got any romantic issues, you can try and solve them there.
Good.
Thank you, Paolo. You're so great. Thank you.
Paolo, I want to wish you the best on this meeting. Thank you all for participating from the European Vitreoretinal Society.
No, we have to thank Retina World Congress to host us. Thank you so much.
Thank you so much. It was really wonderful. You gave us a wonderful opportunity. Thank you.
And if I could remind everyone again, we'll be having more of these e-live sessions in 2020 this year. So please tune in for those sessions in 2020. And as well, look us up on our website, www.retinalworldcongress.org, for our upcoming events and our registration for the 2021 meeting in February of 18th in Fort Lauderdale. We would love for the members of the European Vitreoretinal Society to join us as well. And thank you for anyone who's watching to join us as well at this meeting. George?
Everybody, was terrific. I love it. What's a wonderful time we share together. It's the spirit of RWC to connect people, to connect all the society, to help all the society. I think the Verona meeting is going to be terrific. It's fantastic. The spirit, the people, and the place will be altogether perfect. The scientific level will be outstanding. Here has a little piece of everything we're going to discuss there. And all you said about falling in love in retina, I think all of us here are in love with retina. And to be in a place with nice people discussing retina will be all the perfect. And now I have to thank the people that's behind us, like Debbie Spence, that's the executive director of the RWC. She works a lot. Thiago, with his company, that's helped us technically. And have to address a special thank to Tarek Hassan, the president of RWC. He was the guy who allowed us to connect. And now, see, we are in different places in the world, in US, Brazil, Italy, Turkey, UK, and Czech Republic, and all together in this beautiful Sunday, and we can share knowledge, share scientific topic. I think the future is this. We're gonna have much, much more in 2020 that's gonna connect more people. Thank you very much. I'm very honored, the RWC is very honored to partner with you, and have a very good Sunday, but a special Christmas and Happy New Year. See you all next year. Bye-bye.
Thank you. Thank you.
Thank you
very much.
Thank you.
Bye. Big pleasure.
Very good.
In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the